Thank you. Thank you for the invitation. It's a pleasure to be here in Italy. Today I would like to talk to you about alpha-1 antitrypsin in South America. To begin, I like to show you the red flag. Why a red flag? Because we have to remind that 95% of our patients are undiagnosed. That's why we have to consider that in patients with emphysema less than 40 years, emphysema in non-smoker, liver disease with unclear origin. All of these patients should be tested. The question is, are there patients with alpha-1? This is interesting cases. Let me show you two interesting cases. The first one is a man who began with dyspnea at the age of 38, and the doctor made the diagnosis of emphysema. But it took him 7 years and 5 doctors to get the diagnosis of alpha-1. At that moment, the FEV1 was 40%. The second X-ray is a woman, a psychologist, who began with dyspnea at the age of 38. The diagnosis was emphysema, and she has been seen by 4 doctors, and only 5 years later, the diagnosis of alpha-1 was made. At that moment, the FEV1 was 30%, and she was sent immediately to lung transplant. That is very important information. There are 3 important guides published. The first one, the ERS ATS, published in the Blue Journal 2003. The second is the Spanish, the CEPAR, published in 2006. And the third is the Canadian, published in 2012. But there are nothing written about South America. That's why the Argentine Respiratory Association decided to write our own guide. We work on it and publish it in 2014. It's the first guide published in South America. Related with the prevalence, according to Dr. De Serres and Dr. Blanco, in one case in 1,000 people, is for Argentina. Argentina is a country with 40 million people, and you can see the numbers. The P-set patient is 6.2, and for PS 33.5, and similar in other countries, Uruguay, Chile. The largest country in South America is Brazil, and look at the numbers, PS 5.7 and PS 48.5. Low frequency was found only in 2 countries, Bolivia and Suriname, probably related with ethnic reasons. The severe alpha-1 antitrypsin deficiency affects mainly Caucasians individuals. The prevalence in US and Canada is 1 in 5,000 to 1 in 10,000. And the important thing is it is 5 times less frequent in Latin American countries. And it's estimated that in Argentina there are maybe 18,000 cases with severe deficiency, SZ and ZZ genotypes. But the important thing, most of them undiagnosed. Look at numbers, estimated numbers, 1,500 for ZZ patient. Less than 10% of these patients are diagnosed. SZ, 16,700. And look at the carriers, nearly 500,000 patients. But the prevalence of alpha-1 surpass other well-known diseases like amyloidosis, idiopathic pulmonary fibrosis, pulmonary arterial hypertension, sarcoidosis, cystic fibrosis. That is important. When you suspect a patient with alpha-1, following our guide, we need the alpha-1 serum concentration, and you have 2 results. Normal levels, in this case is no deficiency, below the normal range. If the level is below 35, in this case is severe, 95% of these patients are ZZ. 5% are nulls or other forms of presentation. In this case, you need the genotype. If the level, the range is intermediate, between 35 to 80, in this case is moderate, and you have the SZ, the MZ, and in this case you need the phenotype. The question, in whom suspect alpha-1? In COPD start before the age of 50, COPD without smoking history, family history of COPD before 50 years, family history of alpha-1, vasculitis ANCA-C, chronic liver disease, hepatocellular carcinoma, adult asthmatic with poor response to the therapy, patient with emphysematous bulla in the lower lobes. What are the objectives of the treatment? Preserve lung function, of course, reduce exacerbation, reduce mortality. And what are the interventions we can do? First of all, no smoking recommendation, bronchodilator therapy, infection prevention, augmentation therapy. In Argentina, we screened 1,400 patients with Dr. Mariano Aquier in the Maria Ferrer Hospital, Antonio Cetrangolo. The interesting thing, we found 20 patients ZZ. This is 1.36% of these patients. And this is important. And thus, we have to test all the patients with COPD, regardless the smoking history, because 80% of the alpha-1 patients are current smoker or ex-smokers. As a conclusion, physicians should think in alpha-1 antitrypsin deficiency. There is a high rate of misdiagnosis. Augmentation therapy is safe. It reduces probably the number of exacerbations and delays the progression of emphysema. That's why our useful advice is all COPD patients should have alpha-1 concentration determined at least once in their life. In those with low concentration, their phenotypes should be known. Because alpha-1 is not a rare disease, but rarely diagnosed. And we have the power to change that. That's why our proposal are Alvin Toffler words, because the literate of the 21st century will not be those who cannot read and write, but those who cannot learn and relearn. Thank you very much.